We'll wait for a minute just to allow people to join. Welcome everyone to our lecture today, which is part of our effort under the Stanford Child Mental Health Projects for Ukraine. My name is Antonio Harden. I'm the director of the Child Psychiatry Division here at Stanford. I want to first welcome everyone and thank you for your attendance. I want to thank specifically Dr. Leikauf, who will be talking today about attention deficit hyperactivity disorder. As most of you are aware, we've been doing lecture series for about 3-4 months now, and the topics have focused on mental health issues in children in general, but also in children with autism. In addition to the lecture series, we've been doing a toy drive, and we've shipped so far 3 boxes to Ukraine in collaboration with Child with Hope, but also we've collaborated with Project Hope, and we sent some material also as well, some toys as well. I want to thank Irena and Dimitri for doing the interpretation today. Dimitri will be doing it in Ukraine and Irena in Russian. And also I want to thank Daria and Dana for joining us for the presentation today and providing support. As you will notice, we have a Q&A function here that will allow you to put questions for us, and we'll take the questions. We'll try to answer them at the end of the presentation. Also, we will include a link to our website so you can see what are the upcoming lectures, but also have access to the existing lectures, the one that we've done before, with the translation or interpretation into Russian and Ukrainian. Next month, we have Dr. Jackie Rogers and Mirko Uljarevic on September 7th, who will be talking about restricted repetitive behavior in autism. On September 21st, we have Dr. Karen Beers, who will be discussing parenting strategies to address challenging behavior in autism spectrum disorder. In October, we will have training sessions for individuals and professionals who are interested in administering the CARS, the Childhood Autism Rating Scale, and these seminars will be provided by Dr. Cheryl Kleinman. We will also include a Q&A, in the Q&A, a link to the evaluation. It's very important for us to get your feedback, so please fill out these evaluation so we can get ideas about topics and how to calibrate our presentation. Starting September, the presentation will be twice a month. In September, October, November, and December, there will be only one because of the holiday break, and we'll restart in January. Now, I'm pleased to introduce Dr. John Leikauf, who is a clinical assistant professor here at Stanford in the Department of Psychiatry and Behavioral Sciences and in the Child Psychiatry Division. Dr. Leikauf is an expert in attention deficit hyperactivity disorder. He has published in this field and conducted several research in this research project in this area. He also is an excellent clinician and have a clinical expertise in this disorder, and we usually refer to him on a regular basis to evaluate kids with attention deficit hyperactivity disorder. So thank you, John, for your willingness to contribute to this project. And without further ado, please start.
Okay. Well, yeah, thank you for the kind introduction, and thank you for the opportunity to be a part of this and to contribute in some small way to the project for Ukraine. I'm going to talk a little bit about attention deficit hyperactivity disorder today and cover some of the basics, and hoping for a chance to answer some questions at the end. I just want to acknowledge, this is a photo from UNICEF. I believe this was taken in the, I guess, the eastern regions of Ukraine. It's been in the news, and just want to acknowledge my limited background. And, many other people have been trying my best to get up to speed at just what's in the press, but just to acknowledge the suffering and what seems just to be senseless and unfortunate invasion of Ukraine, and the things that, our focus is on children's mental health, and I'm going to talk today about attention, hyperactivity. These are often symptoms that come up in the context of school and education. Certainly, I think the number I saw, this was, I think, from July, and I'm sure it's higher now, is over 12 million people displaced internally and externally within Ukraine just this year. And so just to, acknowledge, and again, in some small way, that the suffering that the people of Ukraine are going through, and particularly children, and the impacts that has to be having on their education and their development. It's hard to even kind of comprehend and wrap one's mind around. What I'm going to be talking about for attention deficit hyperactivity disorder, many of the symptoms in attention and hyperactivity can also be very similar to some of the reactions that children have to trauma. So I want to just acknowledge that at the outset. I'm not going to go in my slides or presentation into a lot of detail about trauma, PTSD, attachment disruptions, and those displacement, those kind of things. But if people have questions, I'm happy to try to explore those and sort of differentiate. We think of attention deficit hyperactivity disorder as a more of a long-term or chronic condition, and that would be an important way to sort of differentiate. But certainly, both can occur, and so anyway, we can talk a little bit more, but certainly trauma, active disruption is going to complicate diagnosis and treatment without question. Just as a brief overview, I'm hoping to briefly review the history of this disorder, review some of the current guidelines for making a clinical diagnosis of attention deficit hyperactivity disorder, ADHD, briefly review some of the guidelines for treatment, and kind of at a high level talking about both medication or pharmacologic treatment and non-pharmacologic treatment, and then just briefly mention, with what time is left, some of the newer emerging treatment options. In the United States, there's been just in the last 2-3 years, a new medication approved, and 2 new non-pharmacologic treatments approved also. One is like a video game, and the other is a trigeminal nerve stimulator. So hopefully we'll have a little time to talk about those. Okay. So just to start out with, this is a great review by Stephen Ferrone in Nature Review, Disease Primers, a couple of years back. And this is a figure, the timeline. I think sometimes the question arises, is this a new thing? Is this made up by sometimes people say by, drug companies or nervous parents or something like that. They make the case that even back in the 1700s, there were descriptions that I guess closely match what we see with the symptoms of attention deficit hyperactivity disorder, and noticing young children, especially boys, but not exclusively, with a lot of trouble sitting still, trouble paying attention and sustaining attention. But as with, I guess the field of psychiatry in general, there've been several evolutions over the decades, and several attempts to think about, biological influences and try to understand what those might be. With at least in the United States, we use the DSM, the Diagnostic and Statistical Manual, published by the American Psychiatric Association, and revised periodically. We're currently on DSM-5. So, I guess in the kind of mid-century, the term minimal brain damage or minimal brain dysfunction was used with the idea that maybe ADHD symptoms, as there was a growing understanding of neuropathology and the sort of what we say now maybe cognitive control, executive function, functions of the prefrontal cortex, that there wasn't anything that could be obviously found, but that there was the sense that children with ADHD just had a harder time controlling their behavior. And in the 70s into the 80s, a number of factor analytic studies were done looking at a variety of different symptoms, which culminated in the DSM-3 operationalizing specific diagnostic criteria. And I'll talk in a moment about what those are today. But then basically two clusters of symptoms were, I guess, determined to be, specific factors are highly correlated, and that's what we currently use. There have been other symptoms that have, and so that's the attention or inattention and the hyperactivity, impulsivity domains. And there've been other sort of symptoms that have been looked at, particularly emotion dysregulation, or what are termed maybe executive functions around planning and organization, that certainly are often seen and are sometimes studied. Additionally, there's also a symptom cluster that people have termed sluggish cognitive tempo. There's some controversy about whether that's the right term, but I'm not sure who coined it, but that's a term that's been used. There's some other sort of associated symptoms, but that are not currently part of the DSM. As that made it more possible to study, with larger samples at the population level, using the specific criteria, evidence began to accrue of biological influences, particularly genetic influences, which talk about, but also contribution from environmental influences on the symptoms. And although there was some history of using methylphenidate and stimulants going back at least into the 60s, through the 90s and 2000s, the number of treatments has really just grown and grown. Okay. Okay, so just want to highlight some of the kind of important facts about ADHD. It is generally been the most commonly diagnosed psychiatric disorder of childhood. The current estimates are that it probably affects about 5 to 7% of youth, and that there's some evidence that that's been found at a similar rate using the diagnostic criteria translated in other parts of the world as well. CDC did some surveys and asking, has your child ever received a diagnosis, or has your child ever received medication, which, might be a slight overestimate in the sense that perhaps it was a working diagnosis and it was revised, but nevertheless has found that over 10% in some parts of the United States, at least, have received the diagnosis, and that rate has been growing over the last 2 decades. Unclear. I think the consensus is that's probably due to changes in case ascertainment, how cases are identified, rather than something specific about the biology or like an environmental toxin, but epidemiologists are looking into those things. The disorder is more commonly diagnosed in boys than in girls, about 2 or 4 times as often, particularly in early childhood. But by the time we get to adulthood, that gap seems to really even out, and it gradually happens through the course of adolescence. It's unclear if that's due to some sort of genetic difference, or I think what is thought to be more likely is that the hyperactive symptoms are more likely, either more present or more likely to be impairing in boys, or perceived anyway as impairing in boys in early childhood. And so more cases are identified in boys as a result, but that the inattentive symptoms are about as common in boys as they are in girls. They just don't present as obviously in early childhood. Sort of a squeaky wheel gets the grease. Part of what we want to know when we're describing a behavioral disorder is, essentially, what are the outcomes? Like, why do we care? This is part of validating a diagnosis. There are a number of significant functional outcomes that have been observed, where youth with ADHD are significantly more likely, include, having car accidents, general physical injury, being less likely to complete high school or go to college, less likely to be able to support oneself independently into adulthood, significantly more likely to develop a substance use disorder, gambling problems, other risk-taking behaviors, increased rates of incarceration and involvement in physical violence, both as perpetrator and victim, and increased rates of teen pregnancy have been observed. So the general pattern of, these are kind of intuitive, I think, the kind of things related to impulsive behaviors, more difficulty with planning and behavior monitoring, and then certainly with car accidents and physical injury, lapses in attention. And people have looked at the degree to which medication protects against these, and it's a little harder to study, but there are certainly studies that have shown that rates of car accidents, potentially rates of substance use disorder, although that seems to be more neutral, and physical injury go down when people are on their medication. So although there is quite a bit of evidence of biological influences on the symptoms and risk for the disorder, there is no biological diagnostic test. The diagnosis is really made exclusively using the symptom criteria, which can be frustrating for families and clinicians alike. But that's unfortunately the way it is. It seems like whether we're looking at the symptoms from like a parent or teacher rating scale report, which is generally part of the standard of care, or looking at, for example, neuropsychological measures of some of the similar constructs, which don't match exactly, but basically any which way we try to look at the symptoms, what we see is not exactly normal, but essentially a bell curve, and that the symptoms really seem to be the end of a continuously distributed trait or set of traits, and that there probably is some significant heterogeneity, in terms of pathways to the kind of behavioral phenotype. And so, that may be why it's been hard to develop the diagnostic test. The symptoms also, essentially, like many other DSM disorders, part of the criteria is establishing that there's significant functional impairment, which is always going to depend somewhat on the perceptions of the rater and the environmental context. Having said all that, and that leads, I think, to some skepticism. Okay, you're telling me there's something going on with my brain, but you're not measuring my brain. You're just, you're asking my parents or you're asking my teachers. Despite all that, when people have looked using twin studies to try to estimate heritability, it looks like it's on the order of 70 to 80%, which is quite substantial and approximately as high as any, bipolar disorder, schizophrenia, or any of the other psychiatric disorders that we study. There is nevertheless some, environmental influence. Also, just to mention, not to complicate this too much, but it depends a little bit. The heritability estimates depend a little bit on which observer is asked, and so that 70 to 80% number, that's generally based on studies that have looked at a single parent informant, teacher report, self-report, or studies that have tried to integrate multiple parent informants have been somewhat lower, but still generally 40 to 50% or higher, which is still substantial. Some of the, I have here just some estimates with the 95% confidence intervals for the odds ratios, so that basically how much more likely somebody is to meet criteria for ADHD. So being born preterm, very preterm, a very low birth weight substantially increases the risk of developing ADHD later in life. And it sort of makes sense. It's thought that, there's a lot of cortical maturation happening in the last weeks of pregnancy. Iron deficiency, particularly in infancy, and maternal vitamin D deficiency have been shown to somewhat increase the risk. Other toxic exposures in utero, including cigarette smoke, although some of the studies are looking at that tried to control for maternal ADHD found a lower odds ratio, so that maybe that some of it is, as we said earlier, there's an increased risk of substance use, and so it may be that some of that effect is actually just correlated with maternal or paternal genetic risk. Cigarette smoke has been associated as well. Lead exposure in early life has been significantly associated. Interestingly, in high dose, I think high frequency actually in utero acetaminophen, Tylenol, was recently associated with ADHD. Valproate and phthalates, which are found in some plastics. I think blood levels were found to be associated, as well as organophosphate pesticides. But the odds ratios, so increases the risk maybe 50% to 2x. That's definitely substantial, and something worth addressing from a public health perspective, perhaps. But it's also not going to be something that is going to clinically make the diagnosis for you, because the baseline risk is about 5% itself. So this is just not to get too much into the specifics about different parts of the country. I don't think it's understood why this was observed, but this was children 4 to 17, and these were prevalence estimates of parent-reported ADHD throughout the country. So again, this is in 2011. That was an increase over, I think 2000 to 2001 was the previous survey, but with really significant heterogeneity around the country. Again, it could be that there's an environmental influence there, but it's sort of thought that it's more likely to be related to how ADHD is diagnosed, and different theories about that too. And so let's talk about how we do that. Okay, so certainly there's room for some amount of subjective judgment, as there is with many psychiatric disorders. Again, acknowledging the high genetic and environmental influence. In clinical practice, we're still left with trying to get the story, trying to establish the clinical history, using the rating scales to inform that, trying to get multiple informant perspectives when we can. And so naturally, that's going to be somewhat operator dependent. Okay, so one of the keys is just to start out with a persistent pattern. Okay, and that persistent pattern, I think, is really important, of inattention and or hyperactivity, impulsivity that interferes with functioning or development. And is characterized by, I'll show you the list, inattention, hyperactivity, or both. So again, persistent developmental disorder, that it should be present from very early in life. Most of the risk factors that have been identified, we're talking about in utero, early life, toxic exposures, genetic risk. So it's not something that should kind of come and go or suddenly start, at age 25. Of course, it might be diagnosed later in life for various reasons, but there should be some significant history that symptoms have been present for a long period of time. It's also important that it's interfering with function. And so sometimes the interference with function is very environmentally dependent and isn't as obvious in preschool or kindergarten setting as it might be later in elementary school, middle school, high school. I guess those are using kind of US terms, so I apologize for that. So into the teenage years, when more sustained attention, organization are expected, at younger ages, perhaps interrupting physical movement is tolerated, and certainly some of that is developmentally normal. And again, we're talking about the end of a kind of continuum, as opposed to something that's necessarily categorically different. But we do want to see that there's the persistence, so the symptoms have been present, and that there is significant interference with function. And you can have, so this is kind of overwhelming, and just I keep them all up there on the slide because it is a little bit overwhelming to try to kind of remember these clinically. So this is part of why we really, often use the rating scales or checklists to kind of go through all the different symptoms. But basically, there are, among the symptom criteria, 2 lists of 9 symptoms, the 9 inattentive and then the 9 hyperactive impulsive. And to meet criteria, somebody has to have 6 or more for at least 6 months, to a degree that's inconsistent with the developmental level, negatively impacting social and academic or occupational activities or development. At least 6 out of 9 from one list or the other, or both. And then depending on which list a person has 6 of those symptoms, from which a person has 6 of the symptoms, they will be assigned either the inattentive, the hyperactive impulsive, or the combined, what used to be called subtypes, but now are called presentations in DSM-5. So, these are available just to kind of briefly. So often failing to give close attention to details or making careless mistakes, having difficulty sustaining attention in tasks or play activities, not seeming to listen when spoken to directly, mind seems elsewhere even without an obvious source of distraction, although obvious distractions can be distracting too. Often not following through on instructions or failing to finish schoolwork, chores, duties, often having difficulty organizing tasks and activities, or keeping things in order, managing multi-part tasks. People say high activation energy, sometimes avoiding or starting in tasks that require sustained mental effort. A lot of times this is long papers, schoolwork, homework, frequently losing things that are necessary for tasks or activities, keys, glasses, backpack, assignments, being easily distracted by stimuli, and excuse me, again, not to get too much into detail, but it's sort of intuitive. As we get older, some of these are more internal, just as metacognition and self-reflection develop through childhood into adolescence. So there can be more internal stimuli, not in a psychotic sense, but just internal thoughts that can be distracting, or at least adolescents are better at articulating what those might be, and then often being forgetful. And so 6 of these 9, or 6 of these 9, which are a mix of hyperactive impulsives, often fidgeting. And again, these are the ones that are sort of more often identified or thought about, more obvious from the outside, and often lead to younger children getting in trouble, kind of school age. But the most studies have found that it's about not quite 50-50, but about 50-50 inattentive versus a hyperactive impulsive, versus the combined subtype, and that actually the pure hyperactive impulsive is not super common, but often fidgeting, often leaving the seat when you're expected to be sitting, often running or climbing if it's inappropriate, having difficulty engaging in play or other leisure activities quietly, being on the go, or often being driven by a motor, talking excessively, having trouble waiting turns or blurting out answers, interrupting others. And so for older adolescents and adults, at least 5 symptoms are required, and there's some evidence that symptoms started before age 12. And then as part of establishing the persistent pattern is that really there should be some evidence based on the history that these symptoms are really kind of always there. We usually say at least 2 settings. That can be at school and at home, and sometimes it might be around schoolwork in both cases, but 2 settings could be other activities on the weekend, and that we don't want them to kind of, if a teenager also has periods of depression, for example, we would expect that the symptoms might get worse when there's a depression, but that they would also still be there to an impairing degree in periods when there's no depression. For other neurodevelopmental disorders like dyslexia, autism, it's a little more complicated. We do expect those to be there persistently. And so sometimes, we do what we can to try to tease those apart on the history, but we run into limits and sometimes have to kind of make a decision based on what seems to be in the best interest of the child in terms of treatment. But to the extent possible, we want to establish really that these symptoms are consistently there across settings and over time. Again, we want to see that several of them are present prior to age 12. That was relaxed from previous versions of the DSM. 2 or more settings, that they interfere with functioning. And again, just specify whether it's combined, which means 6 from both columns, or the inattentive or the hyperactive impulsive. It's worth just kind of acknowledging too that situations come up where I think the 6 of 9, my understanding, this is a little before my time, but my understanding is that part of that was developed to find basically a cutoff that seemed like, to the people developing the criteria, a reasonable percentage of the population, and also significantly associated with long-term impairment or other sort of negative functional outcomes. They settled on 5%, similar to kind of the way learning disorders are assessed. But you can imagine, and we see this situation where, okay, I give a rating scale to one parent and they have 6 of one and 5 on the other. I give the rating scale to the other parent, they have 5 on inattentive, so it's like 6 inattentive and 5 hyperactive impulsive. And to the other parent, we have 5 and 6. Is that, which, how do we then resolve that? And the truth is that there's some ambiguity there, and it ends up being a clinician judgment. But the good or the bad news is probably partly as a result of that kind of process. You can also imagine if you ask again in 2 years, you might find it's switched, right? It's 6 and it's 4 or something. So the assignment to one of these presentations isn't incredibly stable longitudinally, and doesn't really have a big impact as far as we can see on predicting different functional outcomes or different treatments or anything like that. So, excuse me. Essentially, that's the way to make the diagnosis, and it's good to know, but don't sweat it too much, because partly as just an artifact of how we assess symptoms. There are a lot of cases where it's a little bit hard to resolve which presentation they fall into. Okay. American Academy of Pediatrics put out new guidelines recently, and so just a different professional organization coming at it from more of a general pediatrics perspective rather than child psychiatry perspective. The maybe significant difference there is they're going to be a little bit more concerned with population screening, whereas we're going to be focusing a little bit more on cases already referred to us, maybe more complex cases. And they're going to probably have less time per session, but probably know the families more over, longitudinally over long term. And the guidelines are that basically, ages 4 to 18, and some people hesitant in the kind of 4 to 6 range, but ages 4 to 18 with any academic or behavioral problems where inattention, hyperactivity, or impulsivity is coming up, that the primary care clinician should evaluate. Under age 4, there isn't enough evidence for the diagnosis, and some of the symptoms are so common and age appropriate that it's hard to differentiate. Of course, talking about pediatric interventions, we all love early intervention when we can, but it's just too hard to make the diagnosis. Nevertheless, so medication generally isn't recommended, but the recommendation is to consider parent training and behavior management approaches, which can be beneficial, frankly, for all of us as parents, but particularly for kids who are going to struggle a little more following directions, staying on task. It's recommended to use the DSM criteria. If pediatricians still have DSM-4 rating scales that have normative data down to preschool, that's fine to use. And again, as I mentioned earlier, from age 12 to 18, hyperactivity tends to decrease, and inattentive maybe becomes more impairing. And they recommend getting teacher reports whenever possible, although it can be more challenging as children get older. At least in the United States, they tend to have more teachers in middle school and high school versus kindergarten, elementary school. So, starting around age 11, 12 and up, and each of those teachers may see them only for an hour a day. But it's recommended to get at least 2 when that's possible. And again, to make sure that some of the symptoms started before age 12. And it's also recommended to at least screen for comorbidity, which is common, including substance use or substance abuse, especially for teenagers. Just briefly. So this is highlighting something about prognosis. And so when people have looked over time, we think of it as a persistent chronic disorder with kind of early life risk factors. Symptoms do sort of improve, and to some degree, cortical maturation maybe is playing a role there in kind of top-down executive or cognitive control from prefrontal regions, but symptoms become a bit less frequent. But this is highlighting that there's a gap between the number of people who go into remission if you use the diagnostic criteria. And so it can be, as low as 15% by mid-20s, still meeting, 6 symptoms from one of those lists of 9. However, for the people who, who were diagnosed earlier in childhood, 65% still have functional impairment up to age 30. And so I think it's important to keep in mind. I think, we don't want to scare families too much, but we do want to highlight some of the longer term risks of, not treating the disorder. And it's also something to be keeping in mind when thinking about potentially maintaining treatment over time. I think most people are more interested in functional outcomes and meaningful improvement rather than necessarily, okay, did I have, again, 4 or 5 or 6 of the symptoms to technically meet the criteria? It's more a way to try to kind of right size the number of people who are meeting the full criteria, given that these symptoms individually are quite common, maybe universal, to happen sometimes. Just to say briefly, there are many different genes that seem to be contributing risk. And this is just kind of saying that basically much of the heritability is explained by common variants that contribute a very, very low amount of risk individually, but that in combination, maybe kind of additively and maybe with the interaction effect, many different genes related to just neural growth and regulation seem to come up, as well as some specifically in some of the neurotransmitter systems that we think are implicated, dopamine, norepinephrine, particularly maybe acetylcholine. There are rare chromosomal and low frequency alleles that do contribute a bit more risk, but including Turner syndrome, Klinefelter syndrome, but those are quite rare and certainly not explaining the bulk of cases. And so people are looking at developing like a polygenic risk score, looking at how that might be mediated by some either imaging markers or neuropsychological kind of intermediate markers, but at present we don't have a genetic test. So we think of it sort of like high blood pressure, although it's something that you're sort of born with rather than something that tends to develop. Similarly, that there's a lot of certainly heritability to the disorder, and so we could say it's sort of genetic, but there isn't a gene or a couple genes that we can look at that tell you, do you have it or do you not? And it's not clear whether, to what extent those might coalesce into sort of specific targetable pathways. Time will tell. And similar to hypertension, we have to sort of come up with a number that's associated with like a clinical decision. Is this going to be associated with negative outcomes? And is treatment going to basically be worthwhile where the potential benefits outweigh the potential harms? This is a genome-wide association study. 12 loci appeared as significant, but again, relatively low individual odds ratio. So interesting, exciting that these were found, but again, really not likely to be hugely useful individually in clinical practice. Also, the genetic risk is not as specific to ADHD as, might be nice from a kind of parsimonious kind of diagnostic perspective. And risk is clearly shared with other disorders of impulse control, risk-taking, substance use. depression, educational attainment overall, anorexia, and insomnia, among other things. So, yeah, unlikely that we're going to get a clear kind of, gene chip that's going to say, are these symptoms really due to ADHD or depression, or another learning disorder, unfortunately, anytime soon. And complicating it maybe further, this is from the MTA study, which is a big multi-arm treatment study, and then people were followed longitudinally, naturalistically after a certain point, found that, I believe this was at the initial assessment, but that only about 30% of the young people in the study with ADHD only met criteria for ADHD and no other mental disorder. The most common ones were comorbid disorders were oppositional defiant disorder and anxiety disorder. Certainly that's matches my clinical experience. Conduct disorder is also common, as well as tic disorder and mood disorders. And so, the symptom criteria asks that we establish that it's not due solely to oppositional behaviors, but very commonly people who meet criteria for ADHD also meet criteria for oppositional defiant disorder. So it gets a little tricky, but basically what we're looking for there is trying to establish that, again, the ADHD symptoms are present in multiple settings and persistently, and not occurring only in contexts where a child is basically being asked to follow a rule, and that there isn't sort of a coming and going pattern where there's only maybe in response to sort of a clear external motivator or goal. So kind of a flow chart. This is just a, again, kind of high level schematic. This is not sort of strictly true in a simple way, but we've got the genetic and the environmental risk factors. It's thought that one area that's probably implicated, and this is because the monoamines dopamine and norepinephrine are involved in regulating sensitivity to reward, evaluation of reward expectation, as well as some of the arousal level, the sleep, and some of the executive functions. They're also targeted by the medications that seem to be effective and specific for these symptoms. So, that kind of matches up. But so there's this idea that those are some of the pathways involved, but there probably are others as well. Almost certainly there are others as well. The idea is that, again, there's the balance between the prefrontal and the striatal and limbic systems, and that the prefrontal region is more of the kind of top-down cognitive control, to some extent working memory, planning, kind of risk evaluation, cost evaluation, reward evaluation in the future, and that those are balanced out by reward seeking, kind of drive-based behavior for all of us, and that basically the impulses are winning out more often in young people with ADHD, either because there's something kind of maybe stronger in a sort of simplistic sense or dysfunctional about those impulses, or maybe because there's something deficient or delayed in the prefrontal control. Interestingly, one of the longitudinal findings has been that one of the, probably, again, ADHD is probably heterogeneous, but one of the pathways is that perhaps there's a range, there's variability in how the prefrontal areas are maturing and how pruning is occurring through childhood and adolescence, and that perhaps some of the children with ADHD are just at the late end of that distribution, and that really stands out in a school environment where children are binned by calendar year. And there is evidence actually that children who are younger within their class are diagnosed with ADHD more often. But then again, the idea then is that that then results in a neuropsychological endophenotype that we can measure with cognitive performance measures, assessing domains like sustained attention, working memory, inhibition, and that those sort of underlie some of the symptoms that we observe. Probably not quite that simple, and what we're finding is that there's heterogeneity at each of these levels, and so the people who have measurable differences at one level aren't always, matching up as the same who have the kind of differences we'd predict at each individual level, but people are, Joel Nigg especially, and others are working to figure that out. So we talked a little bit about genetic environmental risk. I want to mention just briefly some of the neuropsychological differences I was just talking about that might be affected by, again, in general, some of the cortical areas that we're mentioning. Inattention, working memory, sustained attention, and then with sustained attention, accuracy as well as reaction time variability are some of the measures that are most commonly found to be affected, as well as what's called either delay discounting or what is it? I'm blanking on the other term, but delay discounting is a term, but basically it's a preference for immediate rewards over delayed rewards. And that's, everybody sort of has that, but they're delay discounting, sorry. Delay, so the degree to which we discount a delayed reward varies. And so children, people with ADHD are found to have a relatively higher preference for immediate rewards compared to the population without ADHD. Working memory is the ability to kind of hold, it was a mental sketch pad, hold several bits of information in your mind actively while you're working on a problem. So remembering a phone number is sort of the classic example there. And there are tasks that sort of ask you to remember, a series of numbers or different pictures of different things. Numbers is one of the most common paradigms. Reaction time variability and accuracy on a sustained attention task. Basically, it's a really kind of boring, long task where you have to watch and maybe X and a Y, or B and a D, or different stimuli will appear, and you're supposed to maybe click when it's one and not the other, or click when you see two in a row of a certain one. And that's supposed to measure how you can sustain attention to something that's not very exciting. Another term for that is vigilance. And then response inhibition, which is different ways of assessing this as well. And they sort of are similar to some of the continuous performance or sustained attention measures, but like it'll be, for example, one paradigm, the word press the button or go shows up, or a green arrow, and then that's showing up 80 or 90% of the time, and then 20% of the time there's a red one, and you're supposed to press as quickly as you can when it's green and not when it's red. And so if you're getting used to pressing when it's green, it becomes harder to stop when it turns red, in an unpredictable order. And so people with ADHD tend to have a harder time inhibiting the response to the red one, the non-target. But none of these, so these have been found by many investigators over the years, and effect sizes are, about 0.5, not, maybe up to 0.7, but none of them are specific enough or consistent enough to be used for diagnosis. Again, unfortunately, people have used the continuous performance task, TOVA is sort of popular, but it's not, it doesn't discriminate well enough to be really considered appropriate useful for making the diagnosis. We still go back to clinical diagnosis. Again, just to visuals are always nice. So some of the areas, cortex, so the parietal cortex, this is sort of associated with talking about alerting, orienting attention, or automatic bottom-up attention. Sometimes you'll hear, which is tied into norepinephrine at a kind of arousal level, and somewhat dependent on experience, of course, as well. But that's kind of a rapidly shifting attention in response to like a dangerous stimulus or somebody shouting your name or something like that. Dorsolateral prefrontal cortex, again, cognitive control, inhibition, planning, working memory, and then ventromedial prefrontal cortex, related area, but maybe more into some of the multi-step complex decision-making. And so these are the areas that have been found in some studies to be, because they're working differently. It's one of the tricky things about fMRI studies is that heterogeneity in study paradigms means that sometimes, the test difficulty is different, the population is different, and sometimes so they often use words like implicated or differentially affected, because you can't always compare one study to the next. But multiple studies have found differences, at least, in how these areas activate in response to some of the tasks I was mentioning in fMRI paradigms. But again, nothing that is consistent enough, discriminatory enough relative to other psychiatric disorders in particular, or with a big enough effect size to be useful at an individual level for making a diagnosis. But nevertheless, I think families sometimes appreciate understand that these might be some of the areas that are affected, and that these relate to some of the symptoms that we're seeing. This is getting into kind of, again, subcortical areas. Amygdala related to, again, salience and fear detection, and somewhat related to alerting or orienting. We say bottom-up attention. Cerebellum has been implicated, which is sort of generally fine-tuning what was thought to be just motor control until I think fairly recently, but also emotion regulation. The nucleus accumbens, striatum, particularly involved in reward and reward expectation, which is complicated too, but again, dopamine keeps coming up, and there's this delay discounting finding and phenotype that shows up. There's a comorbidity with substance use and risk-taking behaviors for sure. Of course, just intuitively, right, our expectation about reward is certainly multi-layered, and some of it's based on even unconscious operant conditioning, what rewards we've experienced, but some of it also is sort of model-based, and related to probably more cortical representations and abstract expectations of reward in the future. And so how all that kind of feeds into kind of final common pathway isn't currently well defined. But again, that area has a lot of dopamine transporters and seems to be implicated. And then anterior cingulate is sort of probably related to kind of internal sense and internal management, but also linked to some of the cortical areas that we're talking about, and connecting the subcortical to the cortical. So it's kind of hand wavy. We don't fully understand exactly, are there specific pathways here that are dysregulated? What we can say is that I think there are enough findings in these different areas of differences in youth with ADHD, particularly using some of those cognitive paradigms that match up with the symptoms as we would sort of expect, and also match up with some of the neurotransmitters that are upregulated generally by the medication treatments that we have. And so there seems to be something there, although again, we don't have a biological test. I think the totality of evidence gives us confidence that there are biological underpinnings to the disorder. This is just showing a schematic of the dopamine from substantia nigra, both up into reward processing areas, as well as into the prefrontal cortex regulating cognitive control, and norepinephrine, which partly is fight or flight, having a lot of projections throughout the brain and body, but regulating kind of homeostasis as well. But definitely has been shown in animal, monkey and mouse models to regulate executive functioning, working memory, in particular, alerting and orienting, and sleep and appetite regulation. So all the medications that we currently have approved for ADHD target norepinephrine. Most of them also target dopamine. And so that kind of lines up somewhat nicely, although again, not to the level of making an individual diagnosis, unfortunately. Yeah, in terms of structural differences, again, there's sort of small difference in overall cerebral and cerebellar volume that's been observed fairly consistently. Some of that is like with a lot of these things, we're sort of turning, for just practical reasons, sort of a continuous symptom into a categorical diagnosis, because we have to make decisions about treatment. And so some of that is just, there's a range of different, of kind of cerebral volume sizes. And if you're looking at the average of the population versus the average of the bottom 5th percentile in terms of these symptoms, you do see an effect. So we could say, that associated with the symptoms for sure. But again, we're not going to be able to use this anytime soon to diagnose ADHD. Yeah, there are differences in dopamine receptor density in the kind of reward areas, and size differences as well. Yeah, the story about nucleus accumbens, substantia nigra, locus coeruleus. I should say substantia nigra, but the brainstem nuclei are kind of difficult to image, and so the more recent studies starting to look at that, but it's been hard to establish, and they're kind of small anyway, so size differences are kind of likely to be minimal. One of the most effective ways to image those, from my understanding, is looking at iron deposits over time. But in young people, just hasn't had time to happen. So there's more looking at sort of late life cognitive effects of hemosiderin deposits, iron deposits in locus coeruleus and substantia nigra. But again, there's a lot of the other evidence that we reviewed points to the involvement potentially of these nuclei, certainly these neurotransmitter systems. And again, there's this kind of general idea of kind of top down versus bottom up. Sometimes the joke is almost like the old days superego versus id, and we know a lot more, but when it comes down to kind of explaining to patients and working with patients day to day, we haven't really advanced all that much, really. We kind of know, what parts of the brain seem to be involved more in those different functions. Okay, so we reviewed a bit about the history, diagnosis, and some of the biological factors that are helpful in understanding the disorder, but that are not unfortunately useful right now for diagnosis. But it still can go a long way kind of in our thinking and with families as well. I think there's just a quick aside, and if this is of interest, maybe we could talk more in detail, but of course, communication with the family is always family specific. You're always trying to develop a relationship with the family, understand their concerns, their way of describing symptoms, family norms to the extent possible. Calling it a biological disorder for some folks is a very helpful way of avoiding shame, blame, negative self-talk, which can sometimes result in anxiety disorders, depression, but even kind of subclinically definitely has a negative effect on well-being, by saying, okay, it's not my fault, like this is something about my brain that's different. Having said that, for some families, some people, it can limit hope and contribute actually to feelings of being damaged or different or deficient somehow, not good enough. And so just to mention that all those things I think just need to be kind of explored to, again, it's complicated topics, but to the extent possible with families in an individual way and with each patient. And sometimes what's really helpful for a parent, is perceived as negative or damaging by the child or the teenager. And so really having some sensitivity to how those topics are introduced is really helpful. And I think also just acknowledging that there is a lot of evidence of biological influence. At the same time, we make the diagnosis based on, self-report, parent report, teacher report, clinician judgment, and those things are inherently and always will be somewhat subjective. And so, I think, just trying to handle those issues with sensitivity and honesty is important. At least in the US, medications are a mainstay of treatment. Some of that is based on the MTA study, which found a much greater effect on core ADHD symptoms for medication relative to behavioral therapy, although the therapy was helpful for additional outcomes like family conflict, anxiety. So we tend to think of, for the core symptoms, medication has been shown most consistently to have the biggest effect size and be the most helpful. But there are a lot of other things, again, that go with it that therapies can be very helpful for, including comorbidity, including oppositional symptoms, including organizational skills. We'll talk about those a little bit in a sec. But so we do often start with medication in the United States. I understand that that's different in Europe, and I'd be curious in the comments if people have more to share. I unfortunately don't know specific regions within Europe and other parts of the world exactly how that might vary. And I do, just have some knowledge that like different medications are approved in different countries. And so I'm sure there are substantial differences, but generally in the United States, we do at least consider medication when the symptoms are significantly impairing and there isn't a contraindication. And basically, within the medication, there are two. One more point I want to mention about the MTA. They found that when they followed naturalistically, even people who had a good response often went off their medications after about 2 years. And so I think just clinically, my sense is one of the reasons for that is side effects. One of the reasons for that also is developmentally, the person's relationship and understanding of what it means to have this diagnosis changes. And so that's an area where, as clinicians, we could be very helpful. Most people will respond to stimulant medications. So again, we have stimulants and we have non-stimulants. The stimulants, methylphenidate and amphetamine, basically. And then there are a bunch of different varying time release packages around those. So immediate release to long release, of lasting kind of 4 to 6 hours on the short end, up to 10 to 12 on the longer end. And then other routes of administration like a liquid, a patch. So there are a lot of different brand names and formulations, but basically those two medications, both are norepinephrine and dopamine reuptake inhibitors, which means they reduce the rate at which those transmitters are reabsorbed back into the releasing neuron, thereby increasing the amount that is present in the synapse and maintaining that for longer. Amphetamine also does stimulate somewhat more dopamine norepinephrine release. It's not clear what difference that has clinically, because the overall effects and the rates of side effects are basically the same, very similar between the two. They are sympathomimetic, and so we get good response rates, but there are common side effects. For most people, they're tolerable, but for some people, they're not. They do increase blood pressure and heart rate modestly, usually not to a clinically significant degree, but that should be monitored. Appetite loss is often present to some degree, for some people, at least a significant weight loss. And so that should be monitored as well. Insomnia is fairly common. Oftentimes that's dealt with by kind of the timing of the dosing and making sure that it's taken earlier in the day so that it's worn off by nighttime, but nevertheless, insomnia can occur. Anxiety, agitation, irritability can occur, as well as dry mouth. Urinary frequency. There are concerns about growth. Studies have differed, but usually we counsel parents on this, that maybe 1 to 2 centimeters less height attainment by adulthood, although some studies suggest that if you follow people long enough, that actually evens out. That, of course, is for most people not really a medical concern, but can be very important subjectively, and it's important that people are aware of that. And cardiac concerns, the main concern is that it's a sympathomimetic. So if there's a conduction abnormality or structural deficit, like hypertrophic cardiomyopathy, that can lead to sudden cardiac death, although it's rare, either through an arrhythmia or valve prolapse. I believe some countries actually screen. In the United States, we don't generally screen, but if somebody has a history of structural heart disease or heart murmur, we usually ask for an evaluation. They are Schedule II because there's abuse potential and diversion potential, so that's something that has to be watched. And there is a risk of cardiac malformations if methylphenidate is used during pregnancy, so that's for women who are becoming or may become pregnant. The non-stimulants, atomoxetine and viloxazine, are norepinephrine reuptake inhibitors. They, in some ways, have similar side effects, but appetite loss, insomnia tend to be much less common. They actually may improve anxiety. There's several studies showing that atomoxetine in particular reduces anxiety, tend to have less dramatic effect on blood pressure, heart rate, and less growth of cardiac concerns. Atomoxetine does carry a black box warning for suicidality and has rare effects on the liver, although, again, screening and monitoring is not recommended routinely. Guanfacine is an alpha agonist, so is clonidine. We don't use that as much anymore because guanfacine is more centrally selective and has long-acting preparations. There's some evidence it's more effective for hyperactive impulsive than inattentive symptoms, but has been shown to improve both. And there's some evidence, although it doesn't carry an indication, that bupropion, which is an antidepressant, can be useful for ADHD as well. I can see that I'm running short on time, so I will speak briefly about, just to mention that along with the rates of diagnosis, rates of medication use vary throughout the country, again, probably due to prescribing patterns and case ascertainment as opposed to environmental differences, although epidemiologists are looking into that. And then for the non-pharmacologic treatments, very briefly, the category with the most robust evidence base is behavior management approaches, which use operant conditioning principles to respond contingently to reward desired behaviors and reduce the rewards that may be occurring for problematic behaviors. The evidence base is strongest for elementary age kids, and it tends to be a sort of top-down from parents or caregivers technique. And so that sort of makes sense. As children get older, developmentally, they desire and need, and it's appropriate to be looking for more autonomy. And so approaches focus a little bit more on incorporating kind of negotiation strategies throughout the family. And there are more studies for organizational skills and executive function training, although there are fewer studies, and so the evidence base is less robust for those than it is for behavior management approaches. And some studies show more improvement in, again, peripheral domains like family functioning, anxiety, rather than the core domains of ADHD symptoms per se. Cognitive behavior interventions aren't as well established for youth. There's good evidence for adults. And these are sort of being adapted down, again, with a heavy focus on organization strategies as well as self-acceptance, and focusing to some degree on relationships and how ADHD impacts functioning and relationships with important others. And then there are physiologic interventions that are not pharmacologic, but things like physical activity. One could argue about whether meditation falls here or the other. Supplements, omega-3 fatty acids, iron supplements, vitamin D. Generally, those have been shown for people who are deficient to be helpful, but not so helpful for people with ADHD just in general. But they're low risk as long as the cost is something that the family is happy to bear, kind of financial cost. Trigeminal nerve stimulation, which is a new treatment, was recently approved, ages 8 to 12, for improving ADHD symptoms. Not clear exactly how it works, but sends a signal to the trigeminal nerve, sensory nerve. It's usually attached to 2 leads of the forehead, kind of sub pain threshold level of stimulation. People wear it at night. makes the nerves refractory, and somehow that's having an effect on EEG findings in the cortex. Wow. And reducing symptoms. One thought is maybe through sleep regulation, but it's not clear. Digital interventions like Endeavor RX, which is a video game that was approved for showing improvements on the neuropsychological test, not on ADHD symptoms per se. So that's kind of interesting, but the bar that the FDA uses for devices is a bit lower than it is for medications. And so these, we say, are kind of emerging treatments, which are interesting, but not well established yet. And since we have medications that, while they may have some side effects, do have high rates of efficacy, we generally start with those before moving on to these other physiologic interventions in many cases, although certainly family preference plays a major role there. Just want to acknowledge Stanford Autism Group for having me. Thank you very much. Funding through the NIMH for my time and helping to prepare the presentation, and the audience and all of you for your time and attention today. Thank you very much.
Very good. Thank you, Dr. Leikauf, for this comprehensive lecture from A to Z, covering the ADHD world in 75 minutes. So we have about 15 minutes to answer some questions. And as usual, that's the fun part here, because you get some good curveballs about the different topics. So the first one: how can we help in the diagnosis of ADHD in very little kids? Since hyperactivity is already there.
Right. So, yeah, I mean, I guess this is going to be maybe an incomplete answer, but what I can say is as I mentioned, AAP doesn't really recommend making the diagnosis younger than age 4. And that is because the symptoms are so common and can be quite sort of situation dependent. However, they do recommend considering treatment for families, behavioral treatment, not medication treatment, but behavioral training methods for families. And so things like, there's a parent-child interaction training or therapy, PCIT, early start, I think, is another one. So I think those are low risk and can be helpful for lots of families with young children who may be having a hard time following directions with oppositional behaviors. And so in a sense, we don't really make the diagnosis. So it's sort of an incomplete answer in that way, but we can practically help. And so I think we can be more liberal with those tools as well, although they can be hard to access. They are relatively low risk. And so I think we don't have to be as careful about, do we quite have enough symptoms? We can say if this is presenting with functional impairment, causing problems for the family, and we can identify a therapy program or direct them to some of the online resources, that can be helpful either way.
Very good. Yeah, something that we've talked before in this group on these lectures is functional impairment and dangerousness to self or others. If the kid is jumping, doing a lot of impulsive stuff, that's when you will be a little bit more prone to diagnose and, most importantly, treat. Let's get to the second question: gender differences in the ADHD presentation among children.
Yeah, so the general point there is, again, not getting too deep into nature versus nurture, but particularly for school-age kids, more boys are diagnosed and more hyperactive impulsive symptoms are observed in boys than in girls. If you're interested, there's a professor at Berkeley, Stephen Hinshaw, who has done a lot of research in looking at girls with ADHD. And so maybe some of his writings might be a great resource, but basically, the symptoms tend to even out by adolescence, or the rates of both the rates of diagnosis and the rates of hyperactive impulsive symptoms. Hyperactive impulsive symptoms tend to decrease over time, much more so than inattentive symptoms as well. And so it looks like early on, we see more boys with the obvious hyperactive symptoms getting in trouble, class clown kind of a phenotype. Inattention maybe is less likely to be impairing or less likely to be picked up by a teacher. But as children develop and get older into teenage years and young adulthood, the rates of diagnosis between genders are much more equal, and inattentive symptoms tend to predominate. So,
very good. Thank you. What kind of treatment is recommended for elementary school kids who have ADHD with comorbid ODD, oppositional defiant disorder?
Yeah, so generally, and again, we base this largely on MTA and some other studies. We would generally recommend combination treatment. And so simplest way to say is for the core ADHD symptoms, medication is often most effective. Again, the behavioral training can be helpful. Organizational skills, usually that's a little more like late elementary, but organizational skills training can be helpful to some degree for the core ADHD symptoms. For the oppositional symptoms, the most effective thing is contingency management, parents or caregivers altering how they respond in terms of, again, operant conditioning principles, as well as in terms of the relationship. But trying to respond more with kind of clear expectations, practicing positive replacement behaviors, rewarding those in a systematic way, and identifying ways in which parents may be inadvertently rewarding some of the problematic behaviors with, for example, attention, or a child gets out of something that they don't want to do, and finding other ways to handle those situations, or adjusting kind of the, say, upstream or the antecedents. What are the contexts? Is it when the child's always hungry, or medications wearing off after school, or if I ask them to do their homework without a warning, whatever the case may be, identifying those situations that often lead to problematic behaviors and finding ways for parents and caregivers to alter those. So those, there's overlap, but those we think of as really targeting the oppositional defiant symptoms. There are a bunch of different paradigms. Alan Kasdan is a great resource. He's at Yale Child Study Center, and has a lot of stuff on his website, and at least in English, some great books for parents. Russell Barkley is another author. I apologize because I haven't looked to see if those are available in translation, but yeah.
Okay, thank you. Question translated from Russian. What are your thoughts about ADHD coaching, and specifically executive function coaching? What's the evidence out there?
Yeah, so there isn't a ton of evidence that I'm aware of for executive function coaching. However, a lot of the principles are very similar to the CBT for adults that have been studied, as well as the organizational skills training paradigm. Oh gosh, I'm blanking on the author's name. I apologize, but it's organizational skills training for ADHD, and it's from the team at NYU. Anyway, so a lot of the principles are similar, and I'll just say anecdotally, I can't say that I have like a study to point you to that has shown that executive function coaching works, but anecdotally, I've seen some people really benefit from it. And the kind of catchphrase that I hear a lot is like, okay, the medication helped me to focus, but I still didn't know what I was supposed to focus on. And so I think, when done properly, and really the kind of the techniques try to coach people to address the difficulties with sustained attention, working memory, and inhibition that we sort of expect. How do I simplify my organization system? How do I make some lists? How do I actually proactively break down a long-term task into component pieces and make those things really simple and explicit and routine? Because what we tend to find is people with ADHD have a much harder time balancing them kind of fluidly in the moment and intuitively than people without ADHD. And so it's often aversive, and having a coach or a therapist can be very helpful, I think, in confronting those challenges head on, and getting support in kind of practicing those skills, but making them sort of very simple, routine, consistent, explicit, so they don't have to be remembered and thought about as often, and then adapting those to the individual. So
very good. Thank you.
Yeah.
For what type of psychotherapy would you recommend? I think you've touched on that. CBT versus DBT. I imagine you did mention CBT.
Yeah. DBT, I'm not sure. I'm not sure if it's been targeted to ADHD, although speaking with ADHD therapists, I think, or DBT therapists, a lot of them find that there's a lot of overlap. And I mentioned toward the beginning that the symptoms of emotion dysregulation are not currently part of the diagnostic criteria, but had been considered at one point. And we certainly see clinical overlap with difficulty regulating emotions, as well as other tasks and things that people have to do. And so some of the distress tolerance, emotion regulation skills, I think anecdotally I've heard from DBT therapists can be helpful, but I'm not aware of a clinical study establishing that for ADHD, and particularly for core ADHD inattentive symptoms.
Very good. Thank you. Do you have any statistical data on comorbidity of diagnosis of ADHD and ASD?
Oh gosh, I don't top of head. Dr. Harden, you might know better than me, but yeah, sorry.
So I think the evidence out there is about 50% of kids with the ASD, they do have some symptoms of ADHD, from executive function to deficits to distractibility, impulsivity. So it's around 50 to 60%. Now, when you look at the specific syndrome in terms of ADHD, it's a little bit less than that. But when you look at community sample of kids with ASD, about 50% they have some symptoms of ADHD. And historically, in DSM-4, we were not allowed to make the diagnosis of ASD and ADHD at the same individual, but with DSM-5, there's been a change, and now it's approved, and you can make both diagnoses. Okay, very good. What kind of recommendation regarding nutrition for individual with ADHD, kids versus adults, if there is any information there?
Yeah, the number of things that people have looked at. So I mentioned some of the supplements. It kind of makes sense, but the clearer evidence of improvement in attention symptoms and hyperactivity symptoms has been in people with a diagnosed deficiency in iron. Is one of the big ones. I think iron is part of the monoamine synthesis pathway, and so it's thought that if you don't have enough iron, maybe you're not making enough dopamine or norepinephrine. But omega-3s have been looked at too, but no supplements sort of generally have been shown to be effective, and it's just sort of recommended the same nutritional advice for kids in general. Balanced diet, less processed food, lots of fruits and vegetables. Every time I talk to a nutritionist, they always tell me it's better if you can get the micronutrients from your diet when that's possible than through supplementation, but supplementation can be helpful. There's also this idea about one of the red food coloring dyes. It's hard to separate that out from processed food in general, but it's one of these where, as the study quality has improved, and same with omega-3s, unfortunately, as the study quality has improved, the effect size has shrunk and shrunk and shrunk and shrunk. And so it's not so clear that is sort of a general recommendation, but still some people will say, some parents really swear when they have certain processed foods or certain food, food with red food coloring, that symptoms get worse, and that there may be a minority of people for whom that's a genuine effect. I hope that's helpful.
Okay, very good. Thank you. Unfortunately, we're out of time, and we still have like 2-3 questions. So it's not surprising. This is a very popular topic, but I think we do have to transition to different work-related things. So I just want to thank everyone for their attendance and for the great questions. And thank you, Dr. Leikauf, for this very comprehensive and informative lecture. And we'll see everyone next time we have a webinar. Thank you for joining, and have a good rest of the day.